I will give today a hemodynamic cases review. I want to start by you knowing all those 4 hemodynamic equations. Print that page and keep it with you during cath lab rotations. The Fick cardiac output equation, which essentially consists of cardiac output equal gross CO2 consumption divided by the other parameters, hemoglobin, by arterial O2 sat minus mixed venous O2 sat. You need to know that, very important. Then the law for vascular resistance, inflow pressure minus outflow pressure divided by cardiac output. Then the valve area equations, Gorlin and Hakki. The simple one, Hakki, essentially consisting of the following parameters: a cardiac output divided by square root of mean gradient, or in case of AS, you can use peak-to-peak gradient instead of mean gradient. Then you have the QPQS equation. I will start by showing this case. This is a hemodynamic tracing obtained during right heart catheterization. This is the same tracing under 50 millimeter of mercury scale and 100 millimeter scale. What chamber is this and what is the diagnosis? So 2 steps. First, identify what is this tracing. Is it atrial, arterial, or ventricular? And number 2, what's the diagnosis implied? What's the first thing you look at when you look at a tracing and you want to identify it? What's the first thing you look at to help you identify that tracing? The first thing, the easiest thing to look at is to see the segment between peaks. This is even irrespective of the EKG. Segment between peaks. Is it mostly horizontal or upsloping? It is not arterial. The arterial pressure is downsloping throughout diastole with a dicrotic notch typically. You have a horizontal or upsloping segment like here, or a clearly horizontal segment here during a long RR interval. This is not arterial. So this is either atrial, which in this case will be left atrial pressure, looking at the range of that pressure, or ventricular. Now, could it be ventricular? There are other features here that tell you it is atrial. The morphology of that, it's very peaky. Both arterial and ventricular have a plateau on top. So that peak is not very narrow, it's wide. When the peak is very narrow and peaky, and sometimes with a slow upslope, sharp downslope, or with equal slopes up and down, this is usually an atrial. In this particular case, a left atrial or wedge pressure. Okay, so using those features, this suggests that what we have here is pulmonary capillary wedge pressure or left atrial pressure. Another thing you can look at is the EKG. If this is a left atrial waveform, this will be a big V wave. When you have high left atrial pressure, what is peaky and high would be a V wave. And you time it to the EKG. Is it peaking after the T? If it's peaking after the T, that further confirms it's a V wave. So the summary, this is left atrial pressure with a large V wave. The 2 questions now: how do you define large V wave, and what is the diagnosis implied by a large V wave? What's the most common diagnosis implied by a large V wave? So 1, the definition of large V wave. We call it large V wave when it is 10 millimeter higher than the mean of the left atrial pressure. So we see the mean here is about 27 millimeter of mercury. If you're higher, that V is higher than 10 plus 27, it's a large V wave. A second definition that is more difficult to fulfill is a V wave more than twice the mean. That's a more severe large V wave. A third definition is V wave over 45 millimeter of mercury. All those 3, any of them implies large V wave. Large V wave is more commonly in practice caused by decompensated heart failure, left heart failure, than by MR. there is that 40% rule with MR. 40% of severe MR cause large V wave, not all of them. It has to be decompensated or acute MR. On the other hand, only 40% of large V wave are severe MR, and in practice, it's probably even less than that. Okay? However, when it's the very large V wave, when you fulfill that criterion of more than twice the mean wedge pressure, then it's likely to be severe MR more than it is heart failure. And this is what this patient had. And I want you to compare in this patient the morphology of the wedge pressure with V wave. Look at it, how it's peaky, how the slopes up and down are nearly equal, and you're horizontal or upsloping diastole versus this. This is the PA pressure in that same patient. Look at it, sharp upslope, slow downslope, and it's downsloping diastole. You really don't get any horizontal segment. It's all downsloping diastole, downsloping. You see that? Also the timing. If you time it, one, the morphology, it's plateaued, not peaky. Two, it's peaking in the STT segment, in the T wave specifically, whereas this one peaks after T wave. This is another case. Can you tell me what's the diagnosis here? What chamber and what's the diagnosis? So yes, I want to consolidate the concept here. This is again left atrial pressure, PC wedge pressure in this case, that is elevated, not as elevated as the last case, mean in the 20s, with again a large peaky V wave. This patient had severe heart failure. He did not have severe MR. Yeah, when you have such a large V wave, the A wave becomes diminutive. Typically in those cases, the atrium is dysfunctional. They have either severe MR, decompensated, or severe heart failure. So the atrial function is impaired and the atrium doesn't contract much. But you can see it. This is an A wave here. This is an A wave here. A that occurs after the P. It starts after the start of the P wave. You see it here. Okay? So I'll show another case. This is simultaneous LV aortic pressure recording. What is the diagnosis? So this is LV in yellow and aorta in pink. What's the diagnosis? HOCM or AS? So you need to know the morphological features that suggest HOCM in this case. The LV features and the aortic features. One, the LV and aortic pressures are hugging each other early on in systole, which is not the case in AS. So they are hugging each other in early systole. Then they split apart and you develop a gradient late in systole. The LV develops that late peaking dagger shape. The aorta develops that late drop, the so-called dome. So it peaks early, spike, then it has a late dome. So late peaking LV dagger, spike and dome aorta with a late peaking pressure gradient. That is very suggestive of HOCM, not aortic stenosis. You need to memorize that slide. It's one of the slides you need to also print. The difference in morphology between aortic stenosis and HOCM. So here is how aortic stenosis looks like. The LV and aortic upstroke do not hug each other. They split apart early on and the aorta peaks late, unlike in HOCM where the aorta peaks early, then it drops late. Here the aorta peaks late. So in AS, the LV and aortic upstrokes are not parallel. The aortic upstroke starts normally for a brief period up until it hits the flow limiting valve area of, let's say, 0.8 centimeter squares. After that, the flow breaks down and you get a drop in the upslope of that aortic pressure and late peaking. And at that flow limiting point, you get a bend. This is what we call anacrotic notch. The other side of dicrotic notch, anacrotic notch, a notch and a bend on the upslope of the aortic pressure. which testifies to the fact that upslope is slow, unlike the sharp upslope of dynamic LVOT obstruction. Okay, so you get sluggish, late peaking aortic pressure. Late peaking, it's what we call pulsus tardus, and sluggish and narrow is what we call pulsus parvus. Whereas with HOCM, you get that early aortic peaking with no gradient early on. The gradient develops later on. What happens, the LVOT obstruction worsens its dynamic, and it worsens throughout systole as the LV shrinks and becomes smaller, which explains why you have late obstruction, late gradient, a late drop in aortic pressure, and a late peaking of the LV after an early bend. You will have a bend on the LV, not on the aorta in the case of HOCM. And the more severe the dynamic LVOT obstruction, the more pronounced that morphology will be, the more spike and dome it will appear. One note, in AS, we don't always have that morphology. And nowadays, in the era of TAVR that is performed in patients who are 85, 90 years old, you don't always have that AS morphology. The more non-compliant your arterial circulation, the less likely you are to have that sluggish upslope and anacrotic notch. You may have a sharper upslope and a wider pulse pressure in all patients with AS. Keep that in mind. Another idea that first-year fellows don't recognize, please remember the 3 types of gradient in aortic stenosis. That slide illustrates those. You have what we call the peak-to-peak gradient, which is not a physiologic gradient, which is what we like in the cath lab. You look at the highest point of the aorta, highest point of the LV. The difference between those is what we call peak-to-peak. You don't get that by echo. Then you have the mean gradient, which is an integration of the pressure in that gray area between LV and aorta. Then you have the peak instantaneous gradient, the green one, which is the highest vertical point. You can draw thousands of vertical points between LV and aorta, and you pick the highest. That's the peak instantaneous gradient. And you need to know the correlation of those gradients. Peak to peak, almost equal to mean gradient, which is almost 2/3 to 70% of that green one, peak instantaneous gradient. And those are the criteria for definitely severe AS. More than 40 for peak to peak and mean, and more than 64 for peak instantaneous, and less than 1 for valve area. The anacrotic notch, especially low anacrotic notch on the upslope, helps support the diagnosis of severe AS. By echo, you do not get peak to peak. It's not a physiologic gradient, but those numbers are the same by echo or by cath. So for doubtful here, let's say you were not sure this is AS versus HOCM. How can you prove one or the other? PVC, what's else? Dynamic maneuvers. Does this gradient vary with some maneuvers? One maneuver is actually just watching the patient for a couple of minutes, and you may see spontaneous variation in the gradient. It can vary with the level of wakefulness of the patient. The gradient can vary with respiration. It may be higher in expiration or actually lower in expiration, depending on the preload versus afterload dependence of that particular physiology in this patient. So here we observe a patient. Here he did not have much of a gradient, but just spontaneously he started to develop a gradient. Those spontaneous variation in gradient support dynamic LVOT obstruction. It varies with breathing and wakefulness or strain. So, and the more you have obstruction, the more obvious the morphology. Note, it's not just dynamic gradient, it's dynamic morphology. So when you develop an obstruction spontaneously, the LV moves from being of normal morphology to late peaking dagger. And the aorta moves from a normal morphology to a spike and dome. Compare this to that. And the more severe the obstruction here, the more spike and dome the morphology. Compare this to that. This is minimal spike and dome. This is a definite spike and dome. So LV and aortic pressure change in morphology, and the gradient changes with dynamic maneuvers or spontaneously. That's a dynamic maneuver. Here we made the patient do Valsalva strain, and you can tell Valsalva strain there is positive thoracic pressure. That's why all of the pressures went up, including that early diastolic pressure. And when we did Valsalva, we went from minimal gradient to a very significant gradient here, okay? And the morphology changed from a normal morphology to, again, late dagger and spike and dome morphology. What do we consider a significant gradient? You need to know the numbers. I mentioned them for AS. For dynamic LVOT obstruction, we go by peak to peak of more than 50 millimeter of mercury with maneuvers or 30 millimeter of mercury at rest. So here it wasn't significant at rest. It was barely 10 millimeter of mercury. It went up to a very significant number of 80 millimeter of mercury for peak to peak. Another note here, with HOCM, by cath we use peak to peak. By echo we use peak instantaneous gradient. Interestingly, for HOCM, the peak to peak approximate the peak instantaneous. So in HOCM, peak to peak approximates the peak instantaneous, not the mean. And the mean is irrelevant in HOCM. So we don't go by mean, neither by echo nor by cath. By echo, we use peak instantaneous, by cath, peak to peak, and it's that cutoff I described, 50 with dynamic maneuvers. And the mean is not relevant because for half of systole, you don't have a gradient. So really physiology correlates with what's happening in end of systole. So you don't want to average the mean throughout systole. To explain what happens with dynamic maneuvers, just remember that important idea. The gradient increases opposite to preload and afterload. So it goes up if preload goes down or afterload goes down. Hence, you get a higher gradient with Valsalva. And the gradient moves in the same direction as contractility. So gradient goes up with contractility. This is another form of dynamic gradient. So this is a patient here. He's not having much gradient at rest. He has a PVC, and post-PVC, he has this. For a first-year fellow, what's this phenomena called? So what we have here is the Brockenbrough phenomena. Post-PVC rise in gradient, but very importantly, drop in aortic pulse pressure. Okay, so it's not just a rising gradient. You get after a PVC a rising gradient with aortic stenosis as well, because you have increased the flow after a pause. But the difference in aortic stenosis is that both aortic pressure and LV go up and the gradient goes up. But in dynamic LVOT obstruction, when you have a post-PVC contraction, you have increased contractility. Therefore, you have increased obstruction. So you don't get just an increase in gradient, you get a drop in flow, dramatic drop in flow. So you get an increase in gradient and LV pressure, but a drop in aortic pulse pressure. And again, anytime you get an obstruction in dynamic LVOT obstruction, you develop that spike and dome morphology. So the Brockenbrough is not just an increase in gradient, it's a drop in pulse pressure of the aorta. It's also spike and dome pronounced aortic morphology. Compare this to that or to that. It's also change in LV morphology, as always, late dagger. And it's explained by the fact that you get an increase in contractility. The preload actually rises after a PVC, but the increase in contractility is so pronounced, it trumps the rise in preload. This is the same patient, okay? He wasn't having much gradient at rest. He had a big gradient with a PVC. Now, this is the same patient. There is no gradient here. And even post-PVC, there is no gradient. What happened here? Compare this to that. Why you're having a dynamic obstruction here and you're not having it here, apparently? The answer is here, you're at a point of the left ventricle where there is no obstruction. You're past the point of obstruction. In Here, the catheter is an end-hole catheter, and it's localized specifically between the HOCM obstruction point, between the LVOT obstruction point and the aortic valve. When you're having an obstruction, your catheter is here, and this is the dynamic LVOT obstruction. When you no longer have the obstruction, you had pull back and your catheter is here. You no longer have an obstruction, neither at rest nor with dynamic maneuvers. And that's actually another way of proving LVOT obstruction. Pull back across the LV using an end-hole catheter to specifically localize the obstruction. So you pull and you see the LV pressure drops within the left ventricle before you get into the aorta. You see gradient inside the left ventricle. And or if you didn't have a gradient at rest, you reach a point within that left ventricle where dynamic maneuvers make no difference anymore. So you're past the point of obstruction. And it's important in LVOT obstruction to use end-hole catheter, not multi-hole, side-hole catheter. If you want to specifically localize the obstruction, if you're not sure there is an obstruction, you want to do pullback, and a side hole will get a contamination between upstream and downstream of obstructions, whether at this level or at that level. So you're not going to be able to localize obstructions. So here we're past the LVOT obstruction. That's why there is no broken bro. It further confirms you have LVOT obstruction. It doesn't negate it. This is another case. This is another LV aortic pressure recording. What's the diagnosis here? So this is aortic stenosis. Note the LV and aortic pressures are not hugging each other. You have late tardis peaking of the aortic pressure with an anacrotic notch. Watch that anacrotic notch. You see it? You don't see it on all beats, but you see it here, anacrotic notch. And of course, you don't have a spike and dome morphology. The LV pressure is not late peaking. So this is a clearly aortic stenosis. The early thing that always should strike you is the upslopes. Are they hugging each other at the beginning, or they are split apart early on? That split apart early on with late peaking aorta and no spike and dome, and the gradient is relatively mid peaking, not late peaking, not a late peaking gradient, that is suggestive here of aortic stenosis. Can you tell if it is severe? Yes, it is severe AS. One, because the peak-to-peak gradient is around 40 millimeter of mercury. Number two, that anacrotic notch suggests severe AS. The lower that anacrotic notch is on the upslope, the more suggestive of severe AS. Again, the anacrotic notch corresponds to the valve area, to the flow limiting point. So the smaller your valve area, the lower that anacrotic notch will be on the upslope. You need a properly damped tracings to see it. It definitely wants to be below the midpoint of the aortic upstroke. If you use catheter with transducers at their tip, micromanometer catheters, normal people will have an anacrotic notch, but it will be high on the upslope. This is another case. What's the diagnosis here? AS. Why? This, I like people to elaborate. That helps you practice in your brain. This is aortic stenosis. One, the LV and aortic pressure are not hugging each other in systole. Two, there is no spike and dome morphology of the aortic pressure. In fact, there is a small anacrotic notch that you may see here. There is no late peaking of the LV pressure, narrow late peaking. So this is consistent with aortic stenosis. And the post-PVC behavior. So after the PVC, you have an increase in contractility and preload, and you have an increase in flow. So you get an increase in gradient because the gradient in valvular disease is flow dependent, as the Gorlin equation attests to. So you get an increase in flow that causes an increase in gradient, but there is an increase in flow, therefore there is an increase in stroke volume in the aorta, so you get a wider aortic pulse pressure. You get a higher LV pressure and higher aortic pressure and higher gradient, but the aortic pressure doesn't damp. past it. You got it? So this is the Hakki equation. For a fixed valve area, when you get an increase in flow, you will get an increase in gradient. Actually, you'll get a squared increase in gradient, meaning if the cardiac output doubles, the gradient will quadruples. So really, fixed valve disease is very dependent on flow. That's why after a PVC and when you change your output, your gradient will change. So don't think that in AS the gradient doesn't rise. It does rise. It's just the morphology is different and doesn't rise as much because the aortic pressure also increases, whereas in HOCM, the aortic pressure drops. Is this severe AS? It doesn't look severe by gradient peak to peak. The peak to peak is in the early 20s. Every box is 20 millimeter of mercury. It's in the early 20s millimeter of mercury. It could be low gradient severe AS, but by gradient, it's not severe. You have to prove the valve area is low to call it severe here, low gradient severe AS. So this is a computer-generated pressure gradient. Peak to peak 21, mean 32, and valve area 1.08. What's the problem with this computer-generated numbers here? Notice a big discrepancy between peak to peak and mean. Mean is much higher than the peak to peak. Is this correct or is there an artifact here? Peak to peak is approximately equal to mean. In about 30% of the cases, mean is actually bigger than peak to peak. So you can have peak to peak lower than mean. However, it's not usually that dramatically lower. So the reason it's lower here is an artifactual issue. This aortic pressure is more delayed than the LV pressure because of tubing and catheter length. It's not a true delay. It's not a physiologic delay. It's an artifactual delay from longer tubing for the aortic pressure measurement. So you need to shift this back leftward. And this is when you shift it backward and you superimpose the point of initial rise of pressures, actually the mean becomes 24 and the peak to peak 21. The reason I want to tell you that is don't just go, please, by computer-generated numbers. Yourself, you need to make the measurement and verify the accuracy of computer-generated measurements. So I usually sit back after the case and I spend 15 minutes reanalyzing all the tracings and numbers. So this patient had an echo showing low gradient, possibly severe AS. Mean gradient by echo was 33, aortic valve area was 0.9, and dimensionless index was 0.29. I want you to know grossly, all those low gradient, possibly severe AS, meaning valve area less than 1 with a mean gradient less than 40 by echo. And the ones with normal EF, grossly, half of them are erroneous measurement. Half of them are not severe AS, are an error. Half of them are an error in measurement, particularly in the measurement of the valve area because of LVOT diameter underestimation. And that generates a lower aortic valve area. So half is mismeasurement. So that's why we did this study. Calculate the valve area for me. You have the peak to peak and the mean. What's the valve area? And I'm giving you the cardiac output. So I want you to know the Hakki equation. You need to be able to calculate that on the spot in the cath lab. It's simple. It's cardiac output divided by square root of mean or peak to peak gradient. So 5.5 divided by square root of 21 or square root of 24. You will get 1.1 if you use a 24, and you'll get 1.2 if you use 21. So it's not severe AS by valve area. So the echo underestimated the valve area. And you can do the Gorlin equation. You need to know the Gorlin equation. But again, remember the big picture. Hakki is simplified just for you to understand the concept. It's cardiac output divided by square root of gradient. Okay, please memorize this. Gorlin is cardiac output divided by square root of mean gradient. They don't use peak to peak in that, or peak to peak is not an option in that. But there are some added parameters. Heart rate, systolic ejection period. Systolic ejection period is a period between this point, the intersection in beginning of systole, and the intersection of LV aorta at the end of systole. And the computer will give you that. It will average it throughout beats. So it's 313 milliseconds or 0.313 seconds. That's systolic ejection period. The heart rate was 66, and there is a constant, 44.3. So you plug all those, you come up with 1.2 centimeters squared. The idea of Hakki is that all those, heart rate by SEP divided by 44.3 and multiply by 1,000 here, all those come back to 1. In this case, patient, they came back as 1.08 or so. That's why your Gorlin is a little bit higher than the Hakki using the mean. Does everyone understand the subtlety of this? Because somebody asked me on YouTube in the past, okay, well, sometimes you get discrepancy. I use the mean gradient by Hakki, I get less than 1. I use the peak-to-peak gradient by Hakki, it's more than 1. And you get discrepancy with Gorlin. So what should you use? The idea from the Hakki paper is that the correlation with Gorlin was strong. Any of those three is okay, whether Gorlin or Hakki using peak-to-peak or Hakki using mean. There could be 1.1 to 0.2 centimeters squared difference. 30% of patients have mean more than peak-to-peak in that paper, which translates into 0.1 to 0.2 centimeters squared difference in valve area calculation between the two ways of Hakki, but also the Gorlin equation. So which one do you pick? Look at everything and look at the clinical pictures, but these are some of the ideas. Verify whether your mean is truly different from peak to peak. One, ensure a proper timing of the aortic and LV upstroke, as I showed. Another thing is a lot of patients get excessive spiking of that LV, what we call underdamping artifact, and I'll show you that later. When you get excessive spiking here, that will exaggerate your mean. So you get here an artifact, what we call underdamping, or sometimes catheter whip artifact. You get an early peak. Normally, the LV pressure is like this. You don't get excessive early peaking. You may have a small early peak, but you don't get excessive peaking. If you get excessive peaking, that's an artifact, and you need to cut it. So this is how the LV pressure looks like. You may have notching in our catheter fluid-filled system on the top of the LV, and we like to see that. But if you have an excessive early notch, this horn here becomes bigger than the second horn, that's an artifact. Something like this, that's an artifact. And that can create a fake peak-to-peak and even mean gradient in those patients. Another idea you can use in those cases is if you have a fib, take the beat with the highest peak-to-peak gradient and the highest mean gradient. Another important idea is post-PVC. That's not an idea much talked about. In those patients with low gradient and possibly severe AS, one issue is low flow that can explain the low gradient. In about 60 or 2/3 of the patient with low gradient severe AS, even with normal EF, the explanation for the low gradient, if it is truly severe AS, is that they have low flow. So how do you increase the flow? Post-PVC. So in the cath lab, just inducing PVC and see what happens to the gradient can help you confirm whether the AS is severe or not. And this has been quantified by 2 papers. And the bottom line is this. Look at the post-PVC gradient. If after a PVC with an increase in flow, you get a mean gradient more than 40, you definitely have severe AS. Meaning, if you're not severe AS, you're not going to get over 40 after a post-PVC, regardless of how premature that PVC is. Now, if after a PVC, you get a gradient, mean gradient, less than 40, that doesn't mean it's not severe AS. It doesn't rule out severe AS. It still could be severe AS, but it doesn't rule it in. So over 40, definitely severe AS. Less than 40, it could be severe AS. You cannot stop there. Another parameter that has been studied by the same Canadian group is mean gradient rises more than 33% compared to the average mean gradient before PVC, more than 33% change is very likely severe AS. This is a relative change. Okay? So remember, 33% and more than 40 after PVC. So use PVC to your advantage, not just for HOCM. So people don't know that. PVC is very valuable in AS. See how high the gradient goes up, particularly in those low gradient, possibly severe AS. Those are the two papers, if you like to review them. How can you prove severe AS aside from PVC? How can you increase the flow and prove severe AS? What's a classic way? Dobutamine, does it apply to patients with normal EF? The way you can increase flow in low gradient, possibly severe AS, is dobutamine, but that only increases flow in a definite fashion in the low EF, low gradient, severe AS, where the contractility is the issue. But when you have normal EF, dobutamine actually may worsen your flow, because when you have severe AS with normal EF, what's impairing the flow in those patients is low preload and high afterload. So when you give dobutamine, it's not a contractility issue. When you give dobutamine, you'll increase the heart rate and shorten the diastole. You will reduce preload. So you're not going to systematically increase the flow because you're reducing preload, which is the flow limiting variable in normal EF, low gradient severe AS. So you give dobutamine, you're not going to increase the flow systematically. So that's why PVC is actually more relevant in that particular case, because PVC increases contractility and it also increases preload. So it's very valuable in those low gradients, severe AS with low or normal EF, unlike dobutamine, which only applies in a definitive fashion to the low EF group. And this is a summary slide of low gradient AS. You may have low gradient AS with normal EF, in which case it could be due to echo mismeasurement half the times, or it could be a truly severe AS with low gradient with low flow, or truly severe AS with low gradient yet normal flow in half the times. And here it's important to do careful echo measurements to eliminate that 50% error. And you may also do cath or valve CT calcium or assess post-PVC gradients. This is different from low gradient AS with low EF. The issue in low EF is contractility, but the issue in normal EF low gradient AS is not contractility. It is rather low flow from poor diastolic filling and high afterload. Dobutamine is used in low gradient AS with low EF, but it does not definitely increase flow in low gradient AS with normal EF. PVC helps in both. This is a 77-year-old man. He had bioprosthetic aortic valve replacement 10 years prior. He presents now with pulmonary edema. He has a troponin I of 1200. He was sent straight to the cath lab and no echo yet. We started with an LV aortic recording, and this is what we got. What's the diagnosis here? So there is a clear pressure difference between the peak LV and the peak aortic pressure. If you take really peak to peak, now this is not simultaneous recording, this is pullback recording. So there are downsides to that. Hard to decide what to match with what. But if you take the highest with the highest, and normally the way I do it, highest with the highest and lowest with the lowest LV with the lowest aorta, and you try to see the gradient for each one of those. And it's in both cases, it's really over 40, it's actually over 50 millimeter of mercury. This with that, for example, or this with that. So it is suggestive of aortic stenosis.
But there is wide pulse pressure as well, right?
Okay, yes.
I'm not sure if he had AR2.
What will more definitely establish AI in this case, in your mind? Yes, there is AI, but what's suggestive of AI in this case? Here is my summary of this. So this pullback suggests aortic stenosis, likely severe by peak to peak, over 40 millimeter of mercury. There is a caveat in the aortic stenosis assessment in this case, is that underdamping artifact. You see that LV? You have an early big horn. Whenever you see an early big horn, this is an underdamping artifact. So the peak LV pressure is unreliable. So this is not here. Let's say this is 180 millimeter of mercury. This is probably not the peak LV pressure. LV pressure is probably somewhere here. This is underdamping. Basically excessive ringing in your pressure transmission, which causes excessive amplification of the pressure peaks and the pressure dips. This is what we call excessive ringing or underdamping. It's the opposite of damping, which is a smoothing of the waveform. So that's a caveat that the peak is not here. The peak is probably somewhere here at the 160. And for this beat, you're about 120. It's still about 40 millimeter of mercury gradient. So it's still severe, but it's not as severe as you think. So there is a catch in the peak-to-peak assessment in this patient. There is an underdamping LV artifact. And by the way, you get more underdamping and catheter ringing on the LV waveform than on the aortic waveform, just because you get catheter impact, what we call catheter impact and whip artifact in the LV. There is more movement of the catheter in the left ventricle because of more swings in the volume of the left ventricle than in the aortic volume. So anyway, there is AS that seems to be severe by peak to peak, although a little bit exaggerated by the underdamping. That's one. So be accurate in your assessment. Number two, now is it truly AS? Let's look at that aortic morphology. There is an anacrotic notch here, less than midway of the aortic upstroke. So yeah, that is suggestive of aortic stenosis. However, the aortic pulse pressure is really wide, and we call it wide when the pulse pressure is more than half of the systolic pressure. So this pulse pressure is 80, while where the systolic pressure is 120. This is a really wide pulse pressure. So I'm starting to think in this bioprosthetic valve, maybe it's not just AS, it's AI. Now, another feature I will add here. What definitely established AI in this case is this. The aortic diastolic pressure meeting or nearly meeting the LV and diastolic pressure. That's the answer I was looking for. That's what we call the triangle of death. On the simultaneous aortic LV waveform in diastole, the LV and aorta meet in end diastole and form that triangle. This is a sign of severely decompensated AI, whether chronic severely decompensated AI as in here or acute AI. In compensated chronic AI, you don't have it. And what we say meet means they are exactly equal, or my experience, they are within 30 millimeter of mercury of each other. And some quantified it as 25%. The difference is 25% of the systolic pressure, less than 25% of the systolic pressure. So yes, here, the aortic diastolic pressure is 40, while the LV and diastolic pressure is early 20. So they are really approximating. Furthermore, the aortic diastolic pressure is very low. That alone suggests AI. The summary is this patient has likely severe AS and likely severe AI with wide pulse pressure, low diastolic pressure of 40, and near meeting of aortic diastolic pressure and LV and diastolic pressure. Now, what does AI do to AS gradient and AS hemodynamic features? And this is, by the way, the aortic morphology in this patient. It is consistent with some AS feature, meaning it has that anacrotic notch and late peaking, although it is very wide for a classic AS. And that's why I'm thinking mixed AS-AI. Now, when you have AI with AS, Inherently, remember the Hakki equation, valve area cardiac output divided by square root of pressure gradient. So when, for a fixed valve area, when the flow increases, the pressure gradient increases in a squared fashion. So in AI, the LV pumps 150 milliliters, 90 millimeters or more than half of it will come back if it is severe AI. Okay? So whatever cardiac output you're getting by thermodilution, the flow across the aortic valve is actually more than double of what is reaching the systemic circulation. What I'm trying to say is, in AI, your AS gradient will rise because you're having a massive flow across the aortic valve. Therefore, all the feature of AS will be exaggerated. So the gradient will be high. Even if the valve area is over 1, you will have a high gradient over 40. You will have an anacrotic notch. Actually, patients with moderate mixed AS-AI do have an anacrotic notch. It's because the AI volume makes AS more hemodynamically significant. That said, in gradient over 40 is still very relevant hemodynamically because it reflects the combined hemodynamic effect of AS and AI. So gradient over 40 still tells you you have a severe hemodynamic effect of that combination of AS and AI, regardless of if one of them is moderate or if both of them are moderate. Actually, in the guidelines, surgery is still indicated for moderate, mixed, moderate AS and moderate AI if it is hemodynamically significant and the patient is symptomatic. This patient's echo confirmed he had wide open severe AI and he had moderate to severe AS. The gradient obtained by echo, the mean gradient was 37 millimeter of mercury, which attests here that we exaggerated the peak-to-peak gradient by the underdamping artifact. Going to show you another case. What's the diagnosis here? This is an LV pressure. This is a systemic brachial arterial pressure. To make it easy for you, analyze systole and diastole. And what's the diagnosis here? The brachial arterial waveform, as in any systemic arterial waveform, compared to the aortic waveform, it is more delayed and it usually peaks higher. You get a systolic peripheral amplification. This is particularly the case if you have severe AI. You get more pronounced systolic peripheral amplification of the peripheral arteries compared to the aortic pressure in AI. But you get it in normal people, especially healthy normal people. The aortic pressure is 120, the peripheral pressure may be 130. So you can get amplification of 10 up to 30 millimeter of mercury, more so in severe AI. So the diagnosis here is severe AI. In diastole, you can see massive meeting of arterial pressure and LV-EDP. This is as bad as you can see. They are not just meeting in diastole, they are meeting in nearly mid-diastole. This is an indicator of very severe AI, and it's actually acute AI. In a chronic decompensated AI, the LV-EDP and aortic diastolic pressure meet, but the aortic systolic pressure is usually not very low because the LV volume is large and you're still generating a large stroke volume. In acute AI, you get that wide pulse pressure, but the aortic pressure is not high just because your LV is not dilated. So the systolic pressure is not high and the pulse pressure is not as wide. You get low diastolic pressure, but the pulse pressure is not as wide as in chronic cases. Now, the more severe that chronic decompensated AI, the more it will mimic acute AI. But this patient had acute AI from endocarditis and valve perforation. Now, does he have aortic stenosis? There is a gradient between LV and arterial pressure. It's a gradient of about 20 millimeter of mercury. The answer is his aortic stenosis is probably mild. Like I said, the massive flow of the regurgitant aortic insufficiency that crosses back the aortic valve causes an increase in the AS gradient. So even if you have a very mild AS, the gradient will be exaggerated. So here, if you have a 20 millimeter of mercury gradient, it's likely a very mild AS. Now, granted that also you have amplification of that arterial pressure, so the aortic pressure is somewhat lower. Still, nonetheless, I think AS is not severe here. It's probably mild. Because of the peripheral systolic amplification, you should typically never do simultaneous femoral or brachial or radial artery compared to LV, because it's hard to tell how much amplification you have. It's hard to compare. The only way to compare is on the pullback, at which time it's too late. On the pullback, you can compare the aortic pressure versus femoral artery or brachial artery and see how much you're getting a rise in pressure. But you should never do that if you're serious about evaluating aortic stenosis. This is another case. This is LV, and this is a brachial artery. What's the diagnosis here? So here is the answer. Let's analyze systole and diastole. So in systole, there is a big gradient between the brachial artery and the LV. It's a huge gradient of over 80 millimeter of mercury. Very suggestive of aortic stenosis. The morphology is suggestive of aortic stenosis, not LVOT obstruction, simply because you have a nice anacrotic notch. That's one. You have a rounded LV morphology. You don't have that late peaking dagger shape, and you don't have a spike and dome. So this is aortic stenosis with anacrotic notch. Now analyze diastole. In diastole, well, you have a very low diastolic pressure in the less than 50 millimeter of mercury, and you have a high LV-EDP of about 40 millimeter of mercury. So aortic and LV and diastolic pressure nearly meet. And the aortic pulse pressure is relatively wide. Actually, the pulse pressure is way more than half the systolic pressure. So we have here definitely suggestion of severe AI. So you have severe AI and severe AS. You have another feature of AI that you don't always have. You have it more in acute AI. No dicrotic notch on a properly damped tracing. This is a properly damped tracing. You see anacrotic notch, yet you see no dicrotic notch. It's not always the case. For example, this patient I just showed earlier, he had severe AI, he had an anacrotic notch, and he had a pronounced dicrotic notch. So having dicrotic notch doesn't rule out AI. Not having it on a properly damped waveform, especially not having it while you have anacrotic notch and you have other morphologic feature of AI, is further support of AI. In this patient, lack of dicrotic notch supports AI, specifically acute AI. The idea here is the valve doesn't close. Therefore, you don't get a dicrotic notch. The pressure continues to drop freely and precipitously throughout diastole, including early diastole. Okay? In chronic AI, the arterial compliance improves and you may get a dicrotic notch from the arterial elasticity. That's why you may not lose it in chronic AI, but you do lose it in acute AI. So the diagnosis now, is AS severe? Like I explained, AI exaggerates the AS gradient. However, this gradient is way too excessive to call it moderate AS. Also, keep in mind that we're using brachial artery, and we have AI, so the aortic pressure is significantly lower. So your gradient between LV and aorta is really very high. So this patient truly had a combination of severe AS and severe AI. This is another recording of LV and femoral artery. What's the diagnosis here? This is dynamic LVOT obstruction. Notice the morphology. The arterial and LV pressure are hugging each other early on. Then you get the spike and dome morphology of the arterial waveform. And you get a bend on the LV. It's almost like an anacrotic notch on the LV, not on the aorta. You get it on the aorta in AS. You get that bend on the LV in dynamic LVOT obstruction, beyond which the LV get a late peaking while the aorta drops in a spike and dome fashion. How do you further prove HOCM? You can do pullback and you can do dynamic maneuvers. This tracing here is in the same patient, LV and femoral artery. Why did we lose the gradient? This waveform where you have elimination of gradient, you could think maybe we pulled back and now we're past the point of obstruction. But if that's the case, the aortic morphology will still be spike and dome. The aortic morphology wouldn't change. And furthermore, the LV morphology past the point of obstruction is similar to the aortic morphology. There is no gradient, and the LV morphology starts to have kind of a spike and dome morphology. This is an example of a pullback in HOCM with a resting gradient. The LVOT past the point of obstruction will have a spike and dome morphology as opposed to a late peaking morphology, and the aorta will maintain that spike and dome morphology. So this is not pullback across the aortic waveform. What is this? In this case, the spike and dome disappeared. So it's not pullback. In this case, the obstruction disappeared. We did something to the patient to make the obstruction disappear. In this case, this was after an LV gram. So you gave a big load of contrast in the LV, you increased the preload, and therefore you eliminated the gradient. And the spike and dome vanished. That's the beauty of dynamic alveolar obstruction. It's not about analyzing the gradient. It's about analyzing the LV and aortic morphologies.